Day, I believe there was a question on a thyroid swelling. An image of a thyroid swelling was given, and one of the options was what is the investigation, the first investigation, and I believe the answer according to the feedback was thyroid function test. So probably I feel the options were thyroid function test, ultrasound, FNSC, or an MRI, or an antibody testing, or whatever. Now, what I want to tell is very difficult for us to guess or get the feedback about the correct options at the correct stem. But you realize there is a theme that is very important, and the theme is very, very clinical oriented. So, based on this theme, I've tried to put the perspective. So, first investigation of choice in a thyroid swelling. What is the investigation? And why is it done as a first investigation? This has got a lot of clinical and pathological significance. They have asked a very deep question. It might look very simple if you have answered it in rote, but it has got a lot of perspective. Now, if you realize, most of the time, all investigations had been done before patient comes to you in some random order. The investigations have been done in some random order. In fact, in your own facility, any thyroid coming in, all the investigations will be done before you are asked to enter the scene. But thinking and analysis should be done in series and not in random order for best outcomes. When you see a thyroid swelling, patient already has an ultrasound report, already has an FNSC, already has a thyroid function test in the hand. They will give it to you, all the file. Your thinking has to be in sequence. Your thinking has to be in series. What do I see first? Even if I've seen the other investigations in random order, what do I take first to analyze? This is what is the right way of looking at a problem. Just because you have to think in series, it doesn't mean you have to send the patient to the first investigation, call back, second investigation, call back and send to the third investigation. You can do all the investigations the same day, but your thinking should start off in series. Okay, so the clinical pictures which I'll be sharing here is just to kindle your interest, to talk about what type of thyroid swellings are there. Never to take you deeper into the picture. Taking you deeper into the picture, the clinical photos will not help. It is the concept that I will be explaining. So have a look. There are three algorithms how you tackle a thyroid swelling. One is a general thyroid swelling, one is a solitary nodule, another one is also a nodule. But look at it. The first thing will be your thyroid function test. Here also almost first. So that means there is some perspective there why a thyroid function test is asked first. Let's come to it. Why these problems arise in a thyroid? Because the surgeon has a perspective, the pathologist has a perspective, and the radiologist will have a perspective. Let's look at the word colloid goiter. They are not on the same page. What the colloid goiter is to a radiologist is different from what a colloid goiter is to the pathologist, and what a colloid goiter is to the surgeon or the endocrinologist. So have a look. Only at a very small portion, all three will overlap and they'll be talking on the same page. This is where the confusion starts. Now that's why I tell thyroid is not as difficult as it looks, provided you're able to peel and get to the deeper layers. So for just one simple example, colloid goiter. For a surgeon, it is a non-toxic, non-malignant thyroid enlargement clinically. So you have different thyroid enlargements. All these can be called colloid goiter. But for a pathologist, the HPE should have colloid fill spaces or follicles. And for a radiologist, they should be well-defined cysts. Now, you may not find defined cysts here. You may not find colloid here. But a surgeon will continue to call it colloid goiter. Or the pathologist might find colloid fill lobules in a picture which the surgeon is not calling colloid. Similarly, the radiologist might call that thyroid colloid goiter. So you see how they are at different pages. At some point only they will come all together. That is why thyroid nomenclature is so diverse. Fine. So you see colloid goiter is also known as endemic goiter, simple goiter, non-toxic, multinodular, uninodular. The list is endless. So as I told you, in these, when you go down the algorithm, you'll be doing ultrasound from the most simple to advanced techniques. Fibroscans can be done, fine needle aspiration, antibody titer, tests done to pick up side effects of drugs or radioisotope, and surgery also. Not all patients of thyroid will be coming to you as the first doctor that you see them. They would have got treated elsewhere. They would have come with a recurrent problem. So there are a lot of tests which will be done. Now let's come to it. Now, thyroid function tests are often used as an initial investigation for thyroid swellings because they provide valuable information about how well the gland is working. This is the endocrine gland. Any swelling there, you will also look at the function. Typically measures level of thyroid hormones if it is overactive or underactive. This information is crucial because it can guide further diagnostic steps in management. So how can it guide? It can help narrow down the potential causes of swelling. Suppose your TSH is high, which is hypothyroidism. You can say, okay, this may be Hashimoto's thyroiditis. Now let me tell you, your Hashimoto's thyroiditis may have one or two specific clinical findings, but it can proceed from a diffuse thyroid to a solitary nodule in the thyroid to even a multinodular goiter. Fine. Similarly, low TSH levels will be hyperthyroidism. That is T3, T4 will be high, so TSH is low due to Graves' disease or thyroid nodules. You see how things are getting used haphazardly. That is why you need clarity. Identifying functional issues. The problem may be nothing much to do with the anatomy. A swelling there which is autonomic and producing thyroid hormones is not obstructing or causing pressure effects on the surrounding organs, but by itself is causing severe functional damage. Your toxic adenoma will be throwing out thyroid hormones and thyrotoxicosis. But just that swelling may be the least cosmetic problem, may not be impinging on the surrounding structures. Assessing the need for imaging or biopsy. It all depends on what you find in the thyroid function test. We'll come to it as you go down the slides. You'll be able to have a. Now, I want you to look at this diagram and take your time. I'll be going through this very, very slowly. There should be no hurry in this. Now let's have a look. This is a normal thyroid. Fine. What happened? There are only three anatomical types of thyroid swelling clinically when you see them first time. It's either a diffuse enlargement. The whole thyroid is enlarged diffusely with no nodules palpable clinically. Or it can be a normal thyroid with one solitary nodule there, which can be the whole lobe or a small nodule. Or it can be a multinodular goiter. The thyroid itself can be enlarged with multiple nodules, or you might find a normal thyroid, but these nodules, when they are there, they will become palpable. I hope this part is clear. Now with this anatomy, what are the possible physiologies? One is physiological. Next is iodine deficiency. Your iodine deficiency can be because endemic or enzyme deficiency or even drugs in your food, the brassica family food, or some drugs like lithium, amiodarone. Graves' disease, which is your primary thyrotoxicosis, it's an autoimmune disease, or even thyroiditis in the initial stages. So this is how a diffuse thyroid, these are the reasons for it. Now, if you look at thyroiditis, what happens? It can slowly go into this phase. They can become multinodular. Of course, they won't be this enlarged, but they can become multinodular. See, over a period, the anatomy change, the same pathology, but the anatomy changes. Your thyroiditis can change here. Similarly, your iodine deficiency and all these fellows who are starting off as diffuse end up here as goiters, multinodular goiters. You see, there is a time zone there, or there is a timeline. The anatomy for the same pathology can become different. Of course, your Graves unlikely to become nodular. I hope this much is clear. Now, coming to solitary nodule, just forget this arrow for the time being. It's not there. Coming to solitary nodule, it can be a toxic adenoma. See, you see this one nodule, or a dominant nodule of a multinodular goiter. There is a multinodular goiter, but one nodule is so big that you could see it clinically as a solitary nodule, or it could be neoplasia. Your follicular adenoma, follicular carcinoma, or your papillary carcinoma. There is no papillary adenoma. Now let's look at the multinodular goiter, normal thyroid size, but some nodules felt thyroiditis. Hugely distended thyroid, multiple nodules, which is endemic. It started off like this, but it became like this. Iodine deficiency started off like this, but over a period of time became like this. Not only that, the internodal tissue became active, autonomous, so you get secondary thyrotoxicosis there. So now let's have a look. With this scenario, you have multiple DDs for each problem, anatomical problem, and some of them can even move on to this particular anatomical issue or anatomical manifestation, provided there is a timeline there. Now I introduce a thyroid function test. This is my clinical diagnosis. This is what I'm having in the hand. I introduce a thyroid function test. Now, when I introduce a thyroid function test, in physiological, it will be normal. The thyroid is just enlarged to keep up the demands of the body. So, physiologically, it will be in your teens and in the pregnancy. So, green is normal thyroid function. So when I had this and I had this DD, of course age also will tell you, but I had a DD, and how do I objectively rule out? I bring in the thyroid function test, normal, so I am here. Okay, now let's go to the next one. Now I bring the thyroid function test, it is raised, but your anatomy is the same. I will think of Graves and thyroiditis. Simple. You just brought a test and you were able to tease between these DDs. Fine. Then let's go to the next one. Suppose your thyroid function test is less, that is your T3, T4 is less and TSH is high. It is iron deficiency, whatever be the reason. That is for you to tease out further. Now here again we are trying to bring in the thyroid function test. Let's see. In a malignancy, your thyroid function test will be normal. So it includes adenomas and carcinomas. Now let's see. You brought in a thyroid function test which shows increase. The red is increased, the blue is decreased, and the green is normal. So it shows a thyroid adenoma. See, when you had this DD, you brought in you introduced the thyroid function test to tease out here. Fine. Now let's bring the thyroid function test to these two. The thyroid function test you brought, thyroiditis, it may be even normal because it would have run off its course. It would have recovered, whereas it was high here, it recovered off here. Fine. Let's see the other one. It could be even decreased because you can go into the late hypothyroid phase. Fine, it could be even that. Now let's see. Iodine deficiency, thyroid function test will be less. Now it could be even normal. This anatomy remained, but your thyroid functions may be normal. Somehow at some point this got sorted out. Your iodine deficiency, or patient stopped taking the thyroid antithyroid drugs or whatever, or they have taken drugs which impinge the thyroid function like your amiodarone. They have sorted it out and it can be even normal. But if it is high, then you call it secondary thyrotoxicosis. A multinodular goiter was there. So it could have been, it was because of iodine deficiency. You may have low thyroid functions. It may have got corrected either because somebody gave thyroid hormone, or the body on its own sorted out the issue, or the internodule tissue might have become hyperthyroid. Your internodular tissue has become autonomous and hyperthyroid, which is your secondary thyrotoxicosis. So for each anatomical entity of the thyroid, you introduce the thyroid function test and you were able to tease out. This is very, very important. So that is why your thyroid function tests are the first to be deployed in any thyroid swelling. Now, after that is deployed, depending on the column, I will decide what I want to choose next. If you understand this, you will know why thyroid function first are done first, and not only that, you will use it to tease your DDs. You will not have this many DDs anymore with you because you introduced a test. Now these are various clinical pictures just to keep you all little interested. Otherwise, I told you this dissection is going to be deeper at the theoretical and the practical level, not just looking at the clinical images. So you have a diffuse goiter here. This is just to tell you how a diffuse goiter looks. This is a diffuse goiter, but clinically hyperthyroid. So it's a Graves' disease. Look at the solitary thyroid nodules. You have one here, one here, one here. The diagnosis can be, as I told you, many. It can be toxic adenoma, it could be follicular cell carcinoma, it could be a follicular adenoma, or it could be a papillary cell CA. Or these nodules which are sticking out are just dominant nodules of your multinodular goiter. These are all multinodular goiter. When they swallow, you can see the nodules better. Otherwise, you have to palpate them to find out. It may not be available on inspection easily. I'll play one or two of these videos. You'll be able to appreciate. See. Just a single nodule moving there. You can see from the side. This is just to show you deglutition. Let's see this. This is very clear cut salty nodule. See? You can nicely see the single nodule moving. It's fine. Now let's see the others. You can see both nodules are there. The very fact two nodules, it is multinodular goiter. Now very difficult to pick that up on inspection, but on palpation it is easier. Right? Here you can see the nodules nicely. See one nodule there and one huge thyroid swelling with two nodules there. Fine. Okay. So first line of investigation will be thyroid function test in all thyroid swellings, I told you. Investigation to confirm will depend. If it is diffuse and there is thyroid function test was high, you will do a lax. your antibodies. In endemic and diffuse, you will not much do anything, you will replace. If it is enzyme deficiency, you can go further with your enzyme assay or genetic studies. Coming to solitary nodule thyroid, you have done your TFT. If it's a toxic nodule, next you will go into the radioisotope test. However, your ultrasound would have been done anyway. If it's a neoplasia, then more you need an ultrasound and an FNSC. You see how the investigation to confirm has become different depending on where you are, whether you're in the diffuse part, whether you're in the solitary nodule thyroid or in your MNG. Suppose in your solitary nodule thyroid and your thyroid function test when normal, you suspect neoplasia and move here. But solitary nodule thyroid, it was a toxic nodule. Either clinically there is thyrotoxicosis or there is in your test, it is hyperthyroid state. You will move in for a radioisotope study, not radioisotope ablation, radioisotope study. Coming to a multinodular goiter, ultrasound will look for features of malignancy in the nodes. You have done the thyroid function test. Now, if it was normal, ultrasound will look for malignancy in the nodules. Now, if it was less, again ultrasound will look for malignancy. But if it was normal, even then ultrasound will try to look for malignancy. And you will do an FNSC when you find something suspicious there. So you see the second line of investigation becomes totally different. But your first line is always thyroid function test. Now as students, by rote you learn. The first test I will do is a thyroid function test. You must know the reason behind it. Everything has a reason. When you read it by rote, then somebody asks you 2 more extra questions, you will fumble. You will try to pick up the wrong option. But when you're strong in your fundamentals and in your concepts, nobody can shake you from that particular concept. So this is it about thyroid. I went really slow because thyroid somehow students get confused. I used to get confused as a postgraduate. I had no clue. I try my best to read by rote, and those days we were having only clinical examination and thyroid function test. Above that, we did not even have an ultrasound when I was doing my PG 40 years ago. Slowly all this ultrasound, antibodies, they started coming into the baggage or the bag, investigation bag, and we are able to refine our diagnosis. So thank you very much, and please do subscribe to my YouTube channel and my Telegram channel. A quiz will be going out very soon based on this particular topic, and students will have doubts over this. Please do ask me so that I can make a reel again. Based on your doubt, I'll be able to make a reel. So please don't hesitate. Don't think this doubt is very silly to ask. No doubt is silly. A doubt is always a serious doubt. It is always to be taken seriously by the student, by the teachers, and also the other students who are watching the presentation. So please do not hesitate to put up your doubts in the comment box. Thank you very much.